when patients don't have that voice to speak up, to ask questions, to push a little bit if they don't understand what's happening, their care, their adherence, their health, their quality of life suffer because they don't know enough to be engaged enough to ask for help.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with ONS member Teresa Thomas, Assistant Professor at the University of Pittsburgh School of Nursing, about patient self-advocacy and how nurses can help patients advocate for themselves. You can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Teresa.
Thank you so much, Jaime. I'm happy to be here.
So throughout our nursing education, we're taught that a central focus of our role as a nurse is to advocate on behalf of our patients to ensure their needs, their values, and preferences are included in their care and are acknowledged and fulfilled. But today we're going to talk about something that perhaps isn't emphasized in the same way. And that's our responsibility as nurses to educate and empower our patients to be their own self-advocate. To start, can you briefly describe what patient self-advocacy is?
Absolutely. Patient self-advocacy is really a concept that our research team has looked at as a form of self-management. I mean, we learn a lot of different ways that patients with cancer have to manage their care in terms of understanding their illness, engaging in symptom management, making sure that they know how to navigate the healthcare system, all of this. And patient self-advocacy is one part of that self-management, where they're really figuring out, okay, what are, like you said, my values, my priorities as someone who's been diagnosed with cancer, going through treatment or in survivorship, and how do I make sure that my needs, values, and priorities are translated to the care that I get? So, of course, that's always important. And we particularly look at, well, what does it mean when a patient is challenged by something, when something goes wrong in their care, when their health is really suffering, when clinicians aren't listening to them? What is it that they can do to push through that, make sure that they're getting high quality care, even in the face of a challenge? So that's really how we have described it, largely as a concept. And then our team has done a lot of work sort of fine-tuning that and looking at very specific behaviors that patients engage in that meet that definition of getting values, priorities, needs met. So if you want to get into the nitty-gritty parts of self-advocacy, we're talking about having excellent communication skills with healthcare providers, being able to find health information that's relevant to them and use that information to make decisions about their care. And even more broadly than looking at the relationship with healthcare providers or health information, this whole other aspect of what it is to be someone with cancer that isn't in the clinical setting, but much more in their social life. So what is it to stay connected to your family members, your friends, to make sure that they know your values, needs, and priorities, that they're giving you the care that you need, but you're also able to maintain your role, whether it be as a spouse, partner, coworker, family member, friend, etc. And so that idea really came through a lot of female health psychology, and women, which most of our work is in, women with cancer told us time and again that their self-advocacy also has a strong social connection part of it. So it's really all three of those things: effective communication with healthcare providers, making informed decisions about their care, and gaining strength through connections to others. That's really how we define the sort of key aspects of what patients do to advocate for themselves.
That's a great description of that. And I can, as a practicing nurse with memories of patients, and, I think most of our listeners will probably have examples in their minds now of patients that embodied those types of behaviors and characteristics and those that maybe didn't, and how those experiences with those patients and their caregivers perhaps could have been very different because of those differences in behaviors. So how does a patient who is able to advocate for themselves, how does that benefit them? And also, how does it benefit their care team?
From the patient perspective, if you think about someone who's really able to pick up, okay, I have something going on, the care is not addressing these symptoms that I'm having that are so distressing. I have a really difficult treatment decision that I need to make about whether it's a type of anti-cancer treatment or adding a clinical trial on or thinking about more end-of-life care issues. For them, it's about making sure that their quality of life is being met, making sure that their symptom management needs are being met, and making sure that they themselves feel like their care is centered around themselves. So we talk about patient-centered care all the time. And as nurses, we're sort of used to hearing about it both from a health systems perspective about, okay, we're collecting patient-reported outcomes. And yes, we're doing these things in our healthcare processes that are supposed to be patient-centered. But at the end of the day, if a patient doesn't feel like the care really is attuned to what is going on in their life and that they don't feel like they're understood or appreciated or their self-worth isn't identified by their care team, then are we really patient-centered? So those are the more, we call them in research, proximal outcomes for self-advocacy. But then we also think about more healthcare utilization. So if someone is able to engage in this upfront discussions and decision-making and social support that they need, then our research and our evidence shows that they're better able to navigate the healthcare system, avoid unnecessary emergency room visits, avoid unnecessary hospitalizations. Oftentimes, and especially our work now is in the advanced cancer setting, and sometimes that is unavoidable. But we also know with different quality metrics that sometimes things can be avoided. And perhaps if, especially since a lot of our focus is on symptom management, if pain is addressed more upfront, if patients know that, okay, here's a health concern that's new, ongoing, alarming, I need to get an answer for this or find a way to manage it and not let it linger and become something that then forces me to the emergency room or for an unplanned hospitalization. And even looking at, what sort of supportive care services they use. Are they getting the additional layers of support that may be available in their cancer clinic or network to provide them with support they need? Social work, navigation, nutrition, palliative care, all of these wonderful services. Are they getting those referrals and being able to make sure that they're surrounded by a true collaborative team that's addressing their needs? So those are really the benefits that clinically and research-wise we focus on for patients. The cancer care team was the second part of your question, and that's really interesting because when we talk to clinicians about patient self-advocacy and what the clinicians are interested in having their patients self-advocate, it's very much an interest in having the patients do a lot of work on their own. Let's help you find the resources online or the community resources that you need to manage your symptoms, to find out about what your diagnosis is, what your treatment options are, etc. Almost like a lightening of the load for the clinicians if the patient is able to engage more. And I don't think that's exactly how our patients talk about self-advocacy or what our work in self-advocacy has shown, because really the benefits to the cancer care team is having someone who's able to work with their clinical care team, communicate with them, partner with them, engage in shared decision-making. And so it's not an off-put of responsibility, but rather it's a coming to where you have equal or at least more space at the table for conversations in the clinical realm about what options are available, what decisions should be made, and patients feel like they're actually understood or listened to by the people who are managing their care. So that may not be exactly what you asked, Jamie, but I think it's one of the really interesting things that we found about how clinicians think about patient self-advocacy, how patients think about their self-advocacy, and what our work is really trying to motivate, which is that patient-centered care with a heavy emphasis on shared decision-making.
That's really interesting. And as I thought through our discussion today and kind of preparing for the talk, that was my initial reaction was like, oh, well, self-advocacy, doesn't that sort of imply like do it yourself? It does a little bit, but like within the right context. And certainly my interpretation of that is really wanting to equip our patients with the information that helps them kind of, as you mentioned, like may not even know what they don't know. And so helping to set right expectations for the patient of like, here's what we need you to tell us from a symptom management perspective. Maybe we need you to communicate how you're feeling. We need an understanding of how you really are experiencing the side effects from this treatment. We can't help you if you don't let us know how you're doing and how we can make things better. And moving on even to those resources, as you mentioned, like if we don't have a clear and accurate picture of what patients are struggling with, what's causing their distress, then maybe we can't inform them of the right resources that we could, help either refer them to, connect them with. So yeah, I don't like that notion of team members liking patients to advocate for themselves to kind of just do it themselves. I like to see that as a partnership with patients to say, we want to help you, but we also need you to help us understand what would serve you the best. But that is interesting that was sort of my initial kind of reflection too. I'm like, well, this sounds like we're just telling them to do it themselves, but that's not at all what it is. So that's great that you expanded on that and really shed some light on that. So when is the best time for a patient to start advocating for themselves in their care?
This is so based on what a patient is comfortable with. When patients are first diagnosed, it is just overwhelming to get that cancer diagnosis, figure out what the options are, come up with a treatment plan, start treatment. It's a lot. So that expectation of, okay, know everything about your cancer diagnosis, become up to date on all the latest treatment plans, all of that is really intimidating right at the diagnostic period. And I'm trying to paint a picture where it's not all about being super informed. Really, it's about making sure that your clinical care team knows what's most important to you. And so even if the clinician doesn't ask you, okay, what's it like at home? Or tell me about your family, or tell me about what you're looking forward to getting back to after treatment, whatever, putting that into the conversation where they understand exactly what your quality of life means to you. They understand what your main goals of treatment are, which really do vary person by person. And again, right when you're diagnosed, you're not necessarily going to know the nuance of, well, actually, this symptom profile of drug A better jives with my life than the symptom profile of drug B. But over time, you may be able to more accurately put your finger on. But if you even start with that, here's who I am, here's what's important to me, what makes me want to get up in the day, what I want to make sure I don't lose throughout treatment. Usually it's quality time with family members. If you have loved ones that have high school graduations, weddings coming up, these are things that we know really drive our patients to do well and to stay engaged and active, and sharing that. And that gives the providers an understanding of, okay, here's what my task is to get this patient there to this point where they can enjoy these things that make them a person and make life worth living. So there's that aspect of just making sure that your care team understands you as a person, your values, your priorities. And then after that, in terms of the best time or the things to be doing to self-advocate, I think that it just comes down to a decision by decision basis. So we have defined self-advocacy in terms of challenges that come up. And so until those challenges really present themselves, it's hard to say how to behave in a certain way, but still making sure that your treatment team knows that you prefer to be a part, or to what level you want to be a part of the discussion, that you want decisions to be presented to you and not dictated to you, so that they know, okay, this is someone who wants to be engaged and wants to know how I'm making my decision and wants to talk through the different options that are available is all really important, because until, as you said, Jaime, until a clinician knows what's going on or how you want to be involved, they can sort of run on autopilot, for better or worse, of how they provide care. And it's hard for them to personalize care to you unless they know who you are and what you want.
As you talk through that, to me, that's the role of the nurse, is to help bridge the diagnostic piece and the treatment planning, bridge that to that patient and what they care about, what they value, what their needs are. And sometimes it's a matter of ensuring the patients know that they have permission to say those things and to interject those things early and often during the course of treatment. Because, as you said, the patients may not or probably don't have any experience or expertise in oncology. And so they might not even know what to offer up or to highlight. But we as nurses, we do know. We do know here maybe is the normal trajectory in terms of a treatment plan. Here's the typical drugs, the drugs that are going to be suggested, and we'll know those side effects and what maybe is likely to come down the road. And so as the nurse, we really fit in the middle there to say, okay, I know what likely is going to be prescribed. And I also need to then reach out to my patient and say, here's what you might want to think about. Here are things to consider. Because some patients, as you said, they're not comfortable speaking up, or they may be unsure of when or how to say that. So it really falls to the nurse to empower that patient early on to speak up and to include themselves to the degree and level that they are comfortable and want. And that's different for every patient too, especially when we're looking at generational differences. But it certainly, I think, is something that nurses need to be proud to shepherd those patients through that experience, and making sure that the patient, hopefully when they do express what is valuable and important to them as part of their care, that we continue to bring that to the surface as part of discussions with their physician or their advanced practice providers, so that we continue to elevate that for the patient on their behalf when they're not there, but continuing to encourage them to bring that information up as it needs to be brought back into the fold.
Absolutely. I agree with everything you said, Jaime. And I want to highlight one thing, because this was a really interesting finding in some of our research, our interventional research in promoting self-advocacy, where we're trying to equip patients with skills of effective communication, informed decision-making, connected strength. Some of the qualitative work where we were asking them about what worked in the intervention, people said time and time again that the language that we gave them to know that this was even an option, that doctors and nurses wanted to hear from them, was novel to them. They could not fathom that this was the expectation or what was desired. And some of this may be generational, I don't know, but that says a lot about sort of how the implicit messages that patients get in the healthcare system about what their role is. And we have to fight against that so that it's very clear to them that until you hear otherwise, you should assume that you can and should be active and engaged in your care and be able to communicate whatever you want to communicate to your providers.
Absolutely. And I suspect, or at least from my own experiences, pulling from my memories, I think a lot of patients come into that experience in oncology, getting a cancer diagnosis of, I'll do whatever you say is the plan, we're going to do that plan. And I think it's important for us to continue to emphasize that there is always a choice. And sometimes it's not always just treatment or no treatment. There's lots of shades in there of different options and things that can be pursued with treatment. But again, until we empower our patients to speak up and make sure we understand what is critically important to them, what really is the most important thing that we can accommodate when we're making that treatment plan, those are things that we need to know from the very beginning. And again, those values might evolve and change over time too. So it's not a one and done conversation, but it's that setting that stage and an expectation that we want you to bring things up and ask those questions and highlight what is or isn't going to work well with your specific needs and values and wants. And so just bringing that back up time and time again to make sure that they know, that information you shared is so important that they don't even know that they can or should add their voice to the conversation. Just, I think, emphasizes the importance of this work and the talk that we're having today. What are the challenges, or what can happen if patients don't advocate for themselves?
So some of the things that we find when patients really struggle to self-advocate is that their care, which we already know the cancer care system is so complex and so fragmented, that people can easily get lost in the system is that when they don't have that voice to speak up, to ask questions, to push a little bit if they don't understand what's happening, is that their care, their adherence, their health, their quality of life suffer because they don't know enough to be engaged enough to ask for help. And that's the biggest thing. Again, so much of our work has really centered in women, where unfortunately this seems to be a bigger issue than what we've seen in our studies with men, where that asking for help and saying, I need support, whether social support or more from my healthcare team, is not innate to us. It takes a lot for us to say, that we're overwhelmed or need something more, especially if it's not being automatically given to us. These are the patients that we see sort of suffer in silence with continual high symptom burden, treatment after treatment, patients who we're not sure why they're not coming to the cancer center to get their treatment. We don't really know what's going on. We struggle to get into their social lives of what potential barriers could be. And their care suffers because of that. They're not getting the recommended doses. They're not getting their side effects properly managed, which of course could then lead to being dose reduced or not being allowed to continue on treatment because the symptoms are just too much. And more so than the healthcare, which obviously is of primary importance, we're also interested in their quality of life. And we see that their emotional, social, physical, religious, spiritual quality of life just goes down because they're not themselves and they don't quite know how to get back to themselves. And that's the saddest part to see, is that going through the physical rigor of cancer treatment is one thing, but feeling like you're not yourself, or we've had several people call it self-worth, this idea that I'm worth fighting for, I'm worth standing up to my providers and insisting that my pain finally get a treatment that actually works, or I have all of these symptoms, no one's taking ownership of it. I have to go to this provider for that thing, that other provider for another thing. Finding a way to get that coordination that doesn't force the patient to be the quarterback, but puts the quarterback position actually in the hands of providers who know the system, are in the system, and can do that care coordination for the patient. So it comes back to, if the providers aren't aware of all of these issues that are going on with someone's health or social life or their personal and emotional health, then they can't be addressed. So do all of those things happen to every patient? No, that's sort of like a spattering of what could happen across different scenarios. And we don't try to paint too gloomy of a picture when we're talking about this with our patients, but all of those things, physical, emotional, social health, are all what we know our patients value. And so why, if there's a remedy for suffering in silence or not getting the care that you need, wouldn't you try to do something? And that's really what happens, is that patients who have perhaps been waiting for their providers to notice that they keep rating their pain as a 10 out of 10, or they keep waiting for the care team to see, oh, we have them coming in on Monday for chemo, Wednesday for palliative care, Friday for nutrition. Maybe we should try to move these appointments together so that this person isn't spending 3 days a week while tired, exhausted, and not feeling well. Maybe we should try to consolidate the different services that they're receiving, rather than waiting for someone to see that. Eventually, patients do figure out. Usually the story is, I thought someone was looking out for me. I thought people were going to move on this. No one is, or something got mismanaged. And now because of that, I know that my role has to be to self-advocate. Otherwise, I'm going to be at the losing end of the situation. So our goal is to be providing those self-advocacy skills earlier so that you're not waiting for the ball to drop before learning the hard way that the best way to get good care is to be vocal, but to set the expectation of being vocal from the outset. And hopefully then involving clinicians too in accepting that and working with those patients.
Absolutely. And as you kind of talk through that, I've been reading recently about sort of distress screening and just that whole notion of assessing for those concerns or barriers. And Some of them are easy to see, especially when you're talking in the physical realm, the symptom management, things that we can maybe measure or are a little bit more evident. Those are the ones that I would say, I don't want to say they're easy to address, but they're more obvious, I think, even if the patient isn't speaking up. But all the other ones that you mentioned, psychosocial, spiritual, whether it's practical, transportation or childcare, things like that, if those are the ones that are harder to solve, but also the ones that we will never know if we don't directly ask. And as you mentioned, not only ask if we are using a screening tool or some sort of way to capture that information, ask it, but then do something with that information when they tell us. And so, it is so important to make sure that we're addressing all facets of a patient's experience, not just the physical or symptom management issues that maybe we have a pharmacologic answer to that concern. The other concerns that are a less simple fix are sometimes the most important ones to address, especially when you're tying this back into a patient's values and what's important to them. Those are the ones that, as nurses, we really have to ask those challenging questions and get a little uncomfortable, even though we know we might not have the answer to how to solve for that problem. We have to show them that we want to know if it is a problem, and we'll work to find those resources and get them connected in ways that can be meaningful to help improve their circumstances. We talked about fragmented systems and things of that nature. What are the other barriers that patients face when it comes to self-advocating for their care?
So I know this isn't something that we measure, perhaps. We know from our prior work, sort of social determinants of health that make patients more or less likely to self-advocate. And those variables, research variables, are education, income. Patients with higher levels of education, higher income, which those two usually go together, are more likely to self-advocate. I mentioned before some generational things, which there's a lot more nuance to it than just how old are you, sort of this idea of older generations sort of being more accustomed to a patriarchal system where the physician is the top of the tier and patient is just supposed to be receiving information from them and getting their marching orders from them and going forward. But even that is more nuanced. Really, I think what we see is people who come in sort of equipped and ready to self-advocate, already have communication skills, already have a handle on how the healthcare system works. So people with a medical background sort of know, for better or worse, what they're getting into. Health literacy skills, being able to understand health information very quickly when they're presented with treatment options, et cetera, can make sense of them enough to make decisions with that information. And then even more broadly, I think it's just a sense of what are you worth? What are you entitled to? So patients sometimes have an issue thinking, can I even ask for this? Sort of like negotiation skills, like, shouldn't I just be putting up with these symptoms because that's the cost of getting rid of my cancer? Why do I think I should be addressing these things? Or am I going to be chasing my tail if I start going after this symptom with that drug, this symptom with some self-management strategies, et cetera? I should just deal with it. But the patients who have really high self-worth and feel more entitled are the ones who are going to have no problem seeing, okay, what can you offer me? What is available at the center? So oftentimes patients have no idea what a navigator is or what a social worker could do for them, that there's financial counselors available to help them with their financial questions, which we know is just a growing and growing concern in the cancer world as costs go up. So all of these things, I think, as patients begin to understand, okay, if I'm not asking for this, if I don't push for it and at least find out an answer if something's available, then it's not going to happen. So if patients have sort of this constellation of characteristics and also this idea about their self-worth and what they're entitled to, then they're more likely to move into self-advocacy. Obviously, our argument with our interventional research is that this is a skill that can be taught. And so even if you're not one of those people who is, pushy is not the right word, but more likely to ask for something, and if you're not satisfied with an answer, ask again, which frankly is against even my nature. can we at least give you the language, the questions to ask, the okay to say, actually, these are things that may be answerable, and it's worth you figuring out with your team if there is a solution in the clinic, in the community, nationally, that could answer your question.
That's really interesting. And you talked through when you mentioned like the symptoms, and some patients may just assume like, I just have to feel this bad. This is just the reality of my situation and there's nothing that can be done. Again, I think back to that initial session. Usually there's kind of a formal education session that we try to have with patients before they fully launch into whatever their treatment trajectory looks like. And it's so important, I think, to set up, again, that expectation of what is quote unquote normal, or, what can be expected, what is something that we are anticipating will be a situation that you will likely experience. And then again, that we have means to mitigate or manage that, and then helping to set the boundaries of like what's not expected or what should not be interpreted as normal that you just have to suffer through. And I think that's a really important focus for nurses as they educate their patients as they go into their treatments, of clearly delineating this is what you can expect, but here's how we hope to manage it, and let us know if it's not working, versus this is not something that is normal that we would expect. We need to know about these things right away. So that might be more specific to those physical symptoms and side effects from treatment. But again, I think that that can be implemented when you're talking about any sort of occurrence that a patient's going through, just helping them to understand that we want you to report those back to us so that we can help manage those in the best way possible. So when patients are wanting to self-advocate, what are some of the actions that are required for them to do that successfully? And then do you have any tips or advice as patients are starting to engage in perhaps a more proactive self-advocacy?
Again, it really centers around, I think, first and foremost, communication. And then the informed decision-making sort of comes part and parcel with that, because that's the getting the information, gathering the resources to help communicate those ideas to your providers or whomever. And the connected strength also is about communication too, since frequently family dynamics also require really good communication skills. So if there was one thing that we would really want to train our patients in terms of self-advocacy, it's that effective communication aspect. And especially our women, who sometimes, because of providers that perhaps we especially see it when it's a male provider and a female patient, but even just the power dynamic, I think, is different for women and sort of what they feel comfortable with presenting. But those communication skills, again, asking questions, that's the biggest thing. And patients tell us they're so afraid to interrupt. And when they're in a 15, 20-minute clinic visit with their provider, they don't even know when they can interject with a question. They don't even know when there's a decision being made, because for so many, especially first-line treatments for cancers, there is a protocol and it's just sort of laid out, like, here is your path. And that may be fine, and patients may be perfectly okay with that. But to go through an entire treatment decision-making visit, or like we have a chemo visit, which may have been what you were talking about, Jaime, where we go over, okay, here's the treatment that you're on. Here are the likely side effects that you may experience, some of the more unlikely ones, other things to be thinking about as you start treatment, and really lay out the expectations for the physical nature of what's about to happen. In those conversations, being able to say, okay, I'm not quite sure I understand this, or can you explain this again about what I should be doing if this happens, what I should be doing if that happens, who do I call for this, who do I call for that? Patients frequently don't understand. They go through those visits, they try to absorb as much as possible. They know they're getting written material, but they feel bad about asking people to pause and restate things or say things in a language that doesn't have a lot of medical jargon or acronyms, or doesn't make any assumptions about what they know or what they don't know. So there's that. Asking questions, I think, is the biggest thing, bar none. And then especially if there's ever disagreement, or if you don't quite agree with what someone is recommending or saying, that is also one of the hardest times for patients to say, okay, I trust you as a doctor. You are my doctor. I want to follow whatever you say. We're sort of putting all of our eggs in your basket, and our faith is that what you're offering us is going to If cure is possible, give us a cure. If cure isn't possible, give me as long and healthy a life as possible. Like, yes, absolutely. I don't want to hurt that relationship, but I also need you to understand that this is not something that I'm looking to engage in, whatever it is. But that bit of pushback is really hard. And so that's what our training programs are really trying to give patients the skills to, again, I keep on saying pushback, and that's not really what I mean, but to respectfully try to engage the conversation and make sure that if there's a question that's not understood or information that's being presented that doesn't sit well with you, that you don't just sit there and let it pass and hope for the best, but that you engage more, ask questions, ask for clarifications. And since this is a nursing audience, sometimes it means, okay, I had my 15, 20 minutes with the oncologist, didn't get very far with that visit, but now I'm going to see my chemo nurse. Now I'm going to see the nurse practitioner or the collaborative care nurse that's providing me with more of the day-to-day support. And frequently they're the ones who do the translation of, okay, here's what the MD said, here's what it really means. And they're the ones who are available to ask questions. And patients frequently know that, and good chemo nurses, collaborative care nurses make themselves available for that. But that's absolutely our moment to shine as nurses in helping patients engage in that communication aspect of self-advocacy.
A great segue along those lines. What are some opportunities for nurses to really empower patients to self-advocate? As you mentioned, whether it's in that sort of post-visit translation or in those in-between visits where perhaps we're providing guidance through electronic health portal messaging or telephone calls. How can we empower those patients to self-advocate in future visits?
Karen Alsbrook, one of our incredible PhD students who's now doing a postdoc at MD Anderson, wrote this wonderful article for CJON about nurses and how they can promote self-advocacy. So I'll try to reiterate some of her work. She used our work in self-advocacy and created sort of this assessment acronym, as we love in nursing, to first assess. Nurses, I think we naturally are assessors in any situation that we're put into, whether professional or social, but really getting a quick understanding of, okay, what is the proclivity of this particular patient to self-advocate? Do they have barriers? Are they more reticent in general? Do they have a heavy disease burden where even if they wanted to, they can't do the mental work and all of the looking on the internet and meeting with people necessary to self-advocate? Is this someone who I'm worried about their social situation, their environmental background, maybe making it harder for them to stand up for themselves? Perhaps they are just more of okay, I'm going to sit in the background. I have other people around me. I'm not going to push anything. I'm just sort of going to slip under the radar, which may work for them in some situations. But again, that's sort of a red flag for, okay, is this someone who's really going to be telling us and upfront about what's going on with them now and in the future when other things could be happening? So the assessment piece is really key. And then from there, sort of moving into action about how to promote the patient feeling like they have the skills to self-advocate. And then also key is alerting other team members, which I know, Jaime, you mentioned, is that we do so much of the work in between team members. And we had this study. The goal of the study was to shine a light on the work that nurses do in a cancer care setting to advocate for their patients. Because we know that nurses already do this, right? Like, we're preaching to the choir here because implicitly and explicitly, this is what we're taught. The hardest thing about that study was capturing what nurses do. So much of it is behind the scenes. It's not, we were recording clinic visits. Sometimes it happened in a clinic visit, but more often than not, it happened after the clinic visit when the nurse was meeting with a patient, right before the patient left, or calling this provider, calling that provider, putting something into the EHR, making a referral, calling the daughter, doing all this extra work, extremely important things. we, from a research angle, were so frustrated because we knew the amount of work these nurses were doing was incredible. There was no easy way for us to capture all of it and capture the quality of all of it too. With more resources, we definitely could. And I still want to do that as a future study, because it is just incredible when nurses are worried that a patient isn't going to be able to do that self-advocacy themselves, how the nurse steps in. And so that absolutely is incredible work. It's also a lot of work. And so that's why part of our motivation too is to be seeing, are there things that, again, are movable targets from the patient side that nurses could be promoting, sort of like that teach a person to fish rather than just giving them fish themselves. So it's a person by person thing. Again, all of this is in the context of what is their illness. So much of our work is in advanced cancer when it's just overwhelming and fraught with heavy disease burden and very weighty topics where it makes it hard. That's not always the case. So as patients move forward in their treatments and move into survivorship, and self-advocacy continues into survivorship with all of those long-lasting effects and need for surveillance, what are the things that nurses can be normalizing, teaching, encouraging to patients so that they're learning those skills themselves?
That's all great information. So I want to pivot just for a moment for one question. We've talked a lot about patients who maybe are unaware that they can or need to self-advocate or feel empowered to do so. But I suspect most nurses also have memories of patients that were very equipped and very loud in their self-advocacy, or maybe sometimes family members that are advocating on behalf of their family member who is actually being diagnosed. And I think we've had experiences where that advocacy can almost feel threatening as we experience that. Can you just shed a little light on maybe how nurses can assess that behavior and interpret that differently so that it doesn't feel like a threat? It feels like an opportunity to collaborate with that patient and perhaps their family.
That's exactly what it is that it should be a collaboration. I mean, it's rare that a patient, from what we've seen, that a patient comes in with that sort of combative, sort of me versus them attitude where I have to self-advocate because people aren't doing things. And if I don't push and push and push, nothing's going to happen. Usually that comes because they have, unfortunately, had an experience where something fell through the cracks or where their care was mismanaged in some way. They ended up needing additional levels of care. Their health got worse. Something happened where they're just like, okay, I can't just be in the passenger seat anymore. I need to be in the driver's seat. And not only do I have to be in the driver's seat, but I have to put on the gas full speed ahead. And I'm going to force these people to listen to me, and I'm going to force them to do what I want. And as you said, that's not collaborative. That's not coming to the table as equalish partners between family, patient, providers, etc. So I think nurses have an excellent ability of understanding where the patient's coming from, what's motivating them to be doing something like that, and ideally sort of working through, okay, we're all on the same team together. We all have the same goal of getting you as healthy and cancer-free as we possibly can with the tools that we have. Let's talk about how best we can work together as a team. And again, we have to give the message to some people to speak up, and we have to give the message to some people about here's the best way to really work together. And here's how our team works at the clinic. Here's how it would work best, not calling and emailing every day about this thing or that thing, but let's come up with a more realistic plan so that we can efficiently address the most pressing issues that you have. Make sure that we are on the same page about what your priorities are, right? Not every concern, but what your major priorities are, and that we're working together. And if there are additional things that you need, not every problem is going to be answered in the clinic, but there's in every city great access to national resources, which so much during COVID have pivoted to having online opportunities for people, which, assuming people have broadband internet, can access, which is wonderful because we don't all, unfortunately, live in cities with comprehensive cancer networks and wonderful advocacy groups like we do here in the city of Pittsburgh. that sort of fill in the gaps of what our healthcare systems can't give and provide emotional support, social support, financial support, all of these things that we know are what make cancer patients, individuals with cancer themselves, but not everything's going to be answered at that clinic. So I think if you can reorient to, again, what the main issues are for a patient, focus on those, reassure them that everyone has their best interests in mind, then it can hopefully bring people to a place where, okay, I don't feel like I have to be pushing, but I trust that my relationship with the people that are providing me care, that they understand me, that they're doing the best they can, that I understand maybe the limits of what they can provide and can go to additional places if they're available to assist, and hopefully not engage in behaviors that would actually be counterproductive to you reaching those priorities that you have.
I think that's excellent summary and reminding. I always try to remind myself, like, the emotions they're displaying, the behaviors they're displaying, this is not a personal attack on me. As you said, this is a result of some other experience that they have been part of or witnessed. And it's going to take time to establish that trust with them, that we are going to do our best to not replicate whatever that experience was. And sometimes it's a matter of having that discussion, especially if a patient really is making it difficult to help because of sometimes how they approach that situation. Having that very frank but kind conversation of saying, this, the way that maybe the tone they're speaking to you, or just sort of the behavior that they're displaying, that we're here to help you. We want to make sure we take the best care possible of you or your loved one. But, it will take us time to establish that trust with you and for you to feel like you can rely on us. And so just know that we're trying the best we can. And sometimes just talking through that with the patient or their family can help to reset the tone of that relationship. And it can be hard, I think, as a nurse, having been in that situation. And a lot of times it's important to remember they're scared, they're frightened, emotions are high, all emotions are high in certain situations. And so removing your own personal ego from the situation and just trying to focus on what is it that they need right now? What is the need that they're asking for? And how can we stay focused on that and kind of turn the temperature down a little bit so that we can continue to focus on meeting the needs of the patient and earning that trust as the relationship evolves. But that's easy to say on a podcast, and it's very hard to do in real practice when everyone's emotions are high. You feel like you're doing your best and it's not always received maybe that way, or you don't perceive it. But that's great advice to keep in mind for patients maybe who are very well equipped to advocate, but maybe not doing it in the most productive way.
Jamie, it sounds like you could be answering a lot of these questions with your clinical experience yourself.
I don't know. The stories live in you forever as a nurse. You'll have those patients, and maybe you can't remember names or faces, but those experiences, they live with you forever. And I just love talking about things and just remembering those experiences myself. And as I said, I'm sure every nurse listening probably has that one. They're like, yep, I remember so-and-so. And, it's important to talk through things too. I think it helps us realize we're all having similar experiences as we work in oncology. So let's touch a little bit more on your research. You clearly have a research focus in patient self-advocacy. Are there any other findings that you've discovered throughout your study?
Right now, the major study that we're working on is testing a self-advocacy intervention. We've piloted, it's a serious game technology. So it's a form of patient education. It's on a tablet. It's supposed to be sort of a novel form of your more traditional patient education. So it's engaging and sort of balancing the educational aspect with the, I would say, fun aspect of games, but ours really isn't the way you would think of a typical video game. It's more a choose your own adventure story with lots of storylines of what it's like to be someone newly diagnosed with cancer and coming up with challenges and having to make decisions about how to self-advocate or not. So that research is ongoing. We're trying to evaluate the efficacy of that intervention. So no findings to report. One of the more recent studies that we've just completed and are starting to write up the results, like I said, most of our work has been in females with self-advocacy, with their own sort of barriers to self-advocacy, communication, negotiation, gender roles, these sorts of things. And we just finished up a study looking at male self-advocacy. So we basically recreated all of our qualitative work in self-advocacy, and we had developed a self-advocacy scale. So reconsidering that entire scale and conceptual model for men and testing out new items. And that was really fascinating. At the end of the day, we found that our scale that worked psychometrically with women also has strong psychometrics with men, which is great. So now we can expand our inclusion in our research to not just focus on women. But as with most research, the quantitative is great. The qualitative is really where the most exciting stuff comes out. And that has just been so enlightening. I think I had mentioned a little bit about some of the gender differences. And I think, Jaime, you actually hit on it before about how patients frequently want to find a provider who has answers and sort of just follow what the provider says. And that's sort of as far as they go, and don't see the continued active engagement that they may need to have. And so our women in our prior studies, it is communication and voicing my concerns and getting pushback and needing to renegotiate constantly with healthcare providers, loved ones about what's going on and what I need, and making sure my voice is heard. With men, that's part of it, but it's really this upfront figuring out what my treatment team is going to look like, putting my trust in my provider. And after that, there's not this concern about the communication, not because the communication was necessarily going well. Frequently, it seemed like the communication was not going all that great because symptoms weren't being addressed and needs weren't being discussed or managed. But the expectations about what the men wanted versus the women wanted were very different. So men were very happy to be getting treatment from the top provider and just sort of fall in line after that. And whatever comes, and it's my burden to bear. But because I'm being treated by the head of the cancer center, or, the number one guy who wrote the book on this, these were the terms that men time and time again were telling us about how they self-advocated, but yet not focused on the ongoing needs during treatment, which is really fascinating, and something that as we expand our work into looking and promoting self-advocacy in men, are definitely going to focus on, like how do we ensure that especially their symptom management needs. I think being a nurse, that tends to be where I focus, and not necessarily treatment decisions, although that's definitely part of what we look at. But, why is it that men wouldn't speak up about their multiple co-occurring symptoms that aren't getting better? And how do we get those to be things that are addressed, short of a daughter, a spouse bringing them up, but
Right.
helping the patient themselves if it's something that they want to have addressed, which usually these are things that people want to have addressed. How do we promote that? So it's the same actions, but it's a very different flavor. And if we had always started with both genders, probably wouldn't have come out as strong. But because we focused just on women and now we're focusing on men separately, has really just been really fun to learn about and go through.
That sounds so interesting, and clearly lots of future research to be done, not only on those different populations, but I'm sure other ways to kind of put the population into different categories and how their responses would be different. It's just so much research to be done. So you've got lots of work to do.
Yeah, it's good.
So if nurses wanted to, if they look at their own practice and they feel like, man, we could do a better job of encouraging patients to self-advocate or trying to implement some of these findings into their work, where could they start, or where would you recommend they go to start to improve their own practice?
So like we were talking about before, it's a systematic assessment where if we're not being purposeful about naming something and looking at it, maybe even entering it into the EHR, that it might as well not exist. And there's been a lot of work in this about, especially around patient-centered care. Everyone heralds the benefits of patient-centered care, but then when you actually look at the nuts and bolts of how we quantify, measure, label our care, it's very rare that you even have in the medical record points when patients were talking about their needs or values, points where we even document what the family situation or the caregiver situation is of a family member. It's provider by provider. Some providers talk about it and put stuff in, and others don't. And nursing notes in the EHR system, whichever network you're in or healthcare facility that you work for, they're all over the place. They're not systematic. It's very hard to figure out what was the actual nursing care that was provided just by the fact of what our electronic medical records look like. Back when it was paper charts, it was much easier. So all of this stuff gets lost. So until there's a systematic assessment of, okay, what is a person's, and, obviously my work is in self-advocacy, but I'd like to have it be broader than that. Like, what is a person's level of engagement? What's their level of wanting to be involved in shared decision-making? Do they want to be the one driving the care, given options, talk back and forth about what's going on? Do they feel comfortable bringing their concerns to their provider or not? Those are things that if it's in the record where people can see, okay, what type of patient am I dealing with here? And is the onus on me to open up with a question? Providers don't necessarily always ask, do you have any questions? Does this all make sense? Repeat back to me what I just said so that I can know that I'm telling you the information in an understandable way. Not everyone does that. So unless someone's clued into the fact that this patient is someone who needs a higher level of engagement or invitation to be a part of their care, then they're not going to know how to do that. So that's where Dr. Alsbrook's study in CJOHN was really nice, because even just with a few questions, being able to assess someone's level of self-advocacy and be able to note that and share that with the team is sort of the first step. And I would love if we could have a quality improvement project about that in our clinic, or if, other people were interested in that, we can add this to the list of studies that we want to do. Does that make a difference? And does that improve the patient-centered care that they receive? And also, does it help the nurse and the care team sort of promote the patient, also knowing that they can be more engaged and ask questions and expect a higher level of care from their providers?
Well, those are some great thoughts and recommendations on how to continue the work and bed some of these practices into individual clinics, even if they're early in their journey. Well, we've had a great conversation today. I feel like we could keep going for another hour or so, but perhaps we should wrap it up just for today. But before we end, we always like to ask a few sort of quick fire questions just to summarize maybe some of the key points that we've touched on today. So to start, what are some common misconceptions about patient self-advocacy?
I think the biggest misperception, just as I think maybe you had even touched on, is that it's the idea of patients doing things themselves. And that is absolutely counter to what we want. It's more that we know that cancer puts people at a disadvantage, makes them feel different from who they are. And what we're trying to do is get them to feel like who they are is the same person they were, maybe slightly different from who they were before cancer, and that their cancer team and their loved ones know and support them for who they are.
I love that. What is something about this topic that's not often discussed, but you wish people knew more about?
I think one thing that's not discussed about self-advocacy, and we're just getting into it now, is the sort of social determinants of health piece and things that are uncomfortable to talk about in terms of different groups' trust in the medical system, trust in their providers, understanding of what it means to self-advocate. And these ideas about entitlement differ from background to background, and that needs more attention. And our group is trying to have more of a focus on this, but it absolutely needs to be a focus of what we're doing, is making sure that we have an inclusive definition, goal, understanding of self-advocacy.
And I would also add that, as you mentioned, self-advocacy is a skill that can be taught and improved for patients, and that we as nurses, I think, shouldn't just accept that, oh, well, this patient is quiet and never asks questions, and this one is loud and likes to be involved. We should go into every patient encounter with an expectation that we want our patients to have their voices heard. And so it's up to us to help teach them and encourage them to do that.
There you go. I like it.
What additional training or resources do oncology nurses need to help understand patient self-advocacy and help to promote it?
So I don't know how much formal education. Usually when people think about advocacy, they could go down the route of more political advocacy, which I know ONS has some excellent resources on. Also, Sigma, our Sigma Theta Tau International Honor Society for Nursing has advocacy training for all nurses to be promoting their patients' values and needs, and is a great place to start in terms of a more formal program. There are also programs in patient advocacy if you're looking at it more from an academic perspective and are interested in that, especially through the University of Wisconsin. But even, I would say, staying with your local professional organizations like your local ONS and even the national ONS, it may not be called self-advocacy. That's sort of the label that our team has put on it and has grown our research program around this idea of self-advocacy. But again, anything that is promoting understanding how to truly get to patient-centered care and patient values and putting patient values at the forefront of our care is going to give you the resources that you need. Of course, nurses are frequently already doing this, but if you feel like you want the extra effort in learning a more formal process, some of these are great resources to look into.
And along those same lines, are there any additional resources for patients or for providers who want to learn more?
Yeah, so I would say that a lot of groups like ASCO, the National Coalition for Cancer Survivorship, they have some great patient-facing resources, including some resources that we use in our study because they're so robust about cancer survivorship. If you look at them, some of them are a little bit outdated, but I think the concepts and the skills are the same no matter what. So talking about the different times in which to self-advocate, the importance of it, different questions to ask, some of these question prompt lists, these are all so important. I know less about provider-facing skills, and that's actually one of the areas where our research will go into later, is providing clinicians with supports and education about promoting patient advocacy. But I think there's a lot more work to do there. There are some great resources. Our intervention right now, of course, is still in clinical trials. We hope that it's efficacious, and if it's efficacious, then since it is an app and a serious game, the plans are to make it freely available through whichever medium we want to have all patients be able to benefit from it, but not yet.
I certainly look forward to seeing the outcomes, and hopefully that will be in the App Store soon. Do you have any final comments to share with us today, Teresa?
No, Jamie, it's been lovely talking with you. I really appreciate this opportunity, obviously, to talk about my work, but it's really not my work. It's my research team's work. I could not do this without the incredible set of oncology nurses, researchers, patient advocates, community organizations that I have partnered with and learned from, being somewhat in the clinical setting, but not in the clinical setting. I so value going to ONS Congress and our local ONS chapter because those are the nurses that really keep it real for me and help guide my research. One of my closest collaborators, Mary McLaughlin, is at UPMC Passivant here in Pittsburgh. And we just have this wonderful partnership because she brings the clinical aspect, I bring the research aspect. It's wonderful. And anyone listening to this podcast who has ideas or interests, wants to talk, please reach out to me. I am always looking for new ideas and how to make our work really relevant to patients and to clinical care. And absolutely, if it can support nursing too, always looking for collaborators. So thank you for this opportunity.
Well, wonderful. Thank you so much for sharing all of your work and your progress and the research that you have done and the future study that you continue to do. And we look forward to seeing how those results turn out.
Thanks, Jamie.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.